In this episode, we continue our conversation with Dr. Alex Barkan, Chief of Bariatric Surgery and Vice Chair of Department of Surgery at Richmond University Medical Center. Dr. Barkan is the founder of the hospital's Bariatric and Metabolic Institute. Last episode, we talked about bariatric services that are performed at RUMC. In this episode, we'll discuss the total bariatric journey, from who qualifies to what the process is like before and after, and life post-surgery. All right, so Dr. Barkan, can you tell us who is a candidate for weight loss surgery?
So we use basic criteria, the body mass index. That's our basic criteria. If a patient has a body mass index of between 35 and 40 and has other medical problems such as sleep apnea, diabetes, they can qualify for surgery. And if their BMI is over 40, that qualifies them for surgery just by itself.
Does a patient need to be in relatively good health to qualify for surgery?
Well, by definition, patients who require surgery probably have some metabolic issues, not necessarily severe, but they probably have some metabolic issues. So by definition, it's a high-risk patient.
And what sort of preoperative tests do a patient go through before getting a weight loss procedure?
So when patients come in for consultation, we do a screening. We screen them for something called stop-bang, which screens them for sleep apnea. If they reach a certain score, then they need a pulmonary consult and possibly a sleep study if they haven't had one or do not use a sleep apnea machine. Also, the same thing goes for cardiology. Patients will undergo cardiology workup, and the cardiologist will decide what they need. If they need a stress test, or if they don't, the cardiologist's decision. Patients will need to see a psychologist or a psychiatrist who assesses their understanding of the procedure, understanding of what they're getting themselves into, and whatever other issues that need to be addressed. They see a nutritionist to go over diet plans, pre and post surgery. A set of labs have to be done, and patients have to be tested for bacteria called H. pylori that can cause ulcers after surgery. So they either get tested through breath analysis or sometimes endoscopy to evaluate the anatomy prior to surgery. So that's sort of the workup in a nutshell that most patients have to go through.
So based on what you're saying, this is not a procedure or where they meet with you on Tuesday, they're having surgery 3 weeks later.
Exactly. Exactly.
What is that time?
So the process on the average is about 2 to 3 months. Recently, some insurance companies, or a lot of them, have changed their criteria. It used to be monthly weigh-ins for 6 months. So there was at least a 6-month waiting period, which, relatively speaking, in Canada is a 7-year waiting period for surgery. So that was probably okay. But the criteria has changed with the advent and with so much surgery being done in the United States. Well, actually, it's not that much, relatively speaking, but more and more, and research showing that it's effective. Insurance companies have changed their criteria, and a lot of them do not require these 6-month waiting periods anymore. They used to require a whole slew of certain criteria, and when they're met, then the patient can have surgery. So the average time is 2 to 3 months.
So the BMI you said is the gauge, and that brings in a variety of different conditions.
Right, as the BMI goes up, or all-cause mortality goes up, cardiac, diabetes, musculoskeletal, everything goes up as the BMI goes up.
And you talked about sleep apnea and other things, right. And those other new conditions that are coming in that people need to pay attention to that aren't typically addressed or associated with potential weight loss?
A lot of people don't know they have sleep apnea. They snore. They've been snoring for years, but they've never been tested. Their spouses, a spouse or significant other can say, you know what, yeah, he stops breathing for a second. I have to give him a nudge to wake him up. So that's severe sleep apnea, but people maybe don't even know. They don't know that they're waking up middle of the night to go to the bathroom. They think it's their prostate, but it's the sleep apnea because they keep waking up. So there's a lot of things that gets discovered during the workup process. Sometimes cardiac issues get discovered patients never knew anything about, or pulmonary issues. So there are some things that are discovered during the workup process.
So you're getting an extensive physical before you even get considered for the surgical procedure itself.
Well, you're sort of considered for the procedure once you qualify, but once you qualify, you then have to make sure that the I's are dotted and the T's are crossed. So yes, they have to have a comprehensive workup and comprehensive clearances prior to surgery. This is an elective procedure any way you look at it, and we want to minimize the risk of the patient, although we know that the patient is high risk in general.
And where in this process do you have that conversation? Like I think gastric bypass would be a better route than this procedure.
So we start the conversation at their first visit. They're provided with literature that has all procedures in it. a video that we've recorded that they have to watch as an educational video that's for half an hour, and the posters are placed on the walls of our office, and we discuss. Well, we try to minimize, the need to make these decisions right away, right now. We have plenty of time to talk about these things. They can think about what they would like. Some people come in knowing what they want. Some people are on the fence. And then there are some people who have had major surgery in the past, and then we have to gear them a certain direction.
What do you find is, I'll say, the number one reason people say, I want this surgery? Is it, I want to have better health, I have a health condition, or is it my lifestyle, I want to look thin? What is the number or the top reasons people saying they want this surgery?
Well, there's multiple reasons. One, a majority of people, before they come to surgery, take about 2 years to make that decision. And they go, they've tried dieting, it's worked in the past, it hasn't worked in the past, and sometimes their doctor recommends it, sometimes a life event that stimulates them to undergo surgery. Sometimes, they're sort of, I've been thinking about it for a while, and I finally made the decision, or a friend had it done and they were successful, and that gives them the courage to come in. It's a combination. People are scared. People are nervous about these surgeries, and they want something done, but they're nervous. And at the same time, they feel like, I'm fine. And, there's sort of an emerging kind of thing in our current culture, body positivity, where it's okay to be obese and it's okay to live that way. Some people try to subscribe to that, but I think eventually that doesn't work as well. So there's multiple reasons why people come in.
Are there any risks associated with these procedures?
So there are. I mean, the number one risk is nausea after surgery. That's the number one risk. It's the most common. Because we are a center of excellence and we have to participate in the quality measures of the American College of Surgeons, all our data is compiled into a national database. And thousands and thousands and thousands of surgeries have been done. And so they looked at 150 criteria of complications after surgery. And number one is nausea. The worst complication can be a disruption of the anatomy requiring further procedures, but it's rare to have that happen.
So somebody gets through all of the process leading up to the day of, they come in for surgery. What is the day of surgery like?
So before they get to surgery, there's a whole workup process. And then after, they can get consented in the office by an extensive consent form, going over every possibility that can happen and understanding. They also undergo a test. They have a quiz at the office that they have to get 100% on. Now, obviously, it's an informational quiz, but true and false. But we go over the answers. If they get it wrong, to make sure that they're clear. If we feel that the patient is not ready for surgery or lacks understanding of what they're getting themselves into, despite an extensive workup, we will send them back home with more literature to read, and then we'll go over stuff again in the future because we feel like they're just not understanding what they're getting themselves into. But most people who go through that process, after they visit us in the office, they also get a pre-op class, what to expect in the hospital, what course of what to expect. You're going to come in the morning, you're going to go prevention testing, you're going to go into the area where you're going to change into a gown, and you're going to be seen by a nurse, and they're going to be given medications, and then the anesthesiologist will see you, and then afterwards you'll be going to surgery. After surgery, you'll be up and about, moving. There's no drains, no catheters. You'll be moving and walking right after surgery, pain control, nausea control. We start you on a clear liquid diet the next day, which is a stage 1 diet. There's 4 stages they have to go through post-operatively, lasting a week a piece, but the clear liquid diet is pretty much liquids you can see through, and mostly clear protein shakes that give them the nutrition. A nutritionist sees them in the hospital. The post-op one goes over again what they can and cannot do, and then they also get their medications in the hospital. So their nausea medication, if they needed vitamins, pain medication, stool softeners, if they need it, get all given to them in the hospital. So they go home, it's more comfortable that way. And they go home the next day or the following day, depending how they feel. They're never pushed out of the hospital. We always make sure that they're okay before they go. Make sure they tolerate their clears, they're walking. They don't necessarily have to pass gas or go to the bathroom before they leave with in a bowel movement, but they do have to feel comfortable before they go home. So that's sort of the process.
And how long is the average surgery?
Average surgery can last from an hour to 2 hours.
Oh, okay. And this is done primarily robotically, or you're opening incisions?
Everything's done with minimal incisions, robotically or laparoscopically, but the incisions are small.
You mentioned the 4 stage. What are those 4 stages?
So this 4 stages of diet lasts for a month. The first stage is liquids, clear liquids you could see through, mostly protein shakes with some Jello.
That's a month?
That's a week.
It's a week. Okay.
The second stage is the second week, which has liquids you don't see through, but it's still liquids, mostly, again, protein shakes, and followed with yogurts and some other items. And it's all listed in their app that they're given before the surgery, and also on paper if they need it. And the third stage is soft, and the fourth stage is regular food. Regular food doesn't mean we're going to steaks and chickens. We're going with soft fish. We're going with soft vegetables. We tell patients they should stay away from hard meat for 6 months. And of course, staying away from alcohol and carbonated beverages also for that period of time. So it takes time. It's a learning curve. Some patients' learning curves are different than others because in a way it's sort of like muscle memory, right? You're sort of used to living a certain way. When you go to the shower, you first wash your hair, then your body. If you do in reverse, you get confused. Same thing here. You have to sort of relearn a new way of being, and that takes some time.
They're home in a couple of days.
They home in a couple of days. But still, what happens, the anatomy is very small, physically small. The diameter is less than a quarter. When we test the anatomy during surgery, we test it with 30 cc's of fluid. A glass of water, too, has 240 cc's.
Oh, wow.
So you can imagine that, they don't necessarily understand the concept that they have to sip, not gulp. It takes a while to get used to that.
And is that something that they kind of have to live with, forever? Or is it just the initial period and then they can eventually get back to eating and drinking what they weren't?
So some patients, their food tastes change. They don't have necessarily the cravings they had before surgery, and they physically can't fit the food in. So their diets change. Those that are very in tune with the surgery and the compliant, they continue a certain lifestyle, a certain way of living, choosing their foods. For example, you have to have 60 to 80 grams of protein a day. So that's your first go-to. And so they'd have that first because protein takes longer to digest. It has more dense calories, and so meaning that it takes longer to digest, and the patient gets fuller quickly. So proteins are first. And it gets easier to eat after a while, with the sleeve particularly. It gets easier. And sometimes the appetite that disappears after surgery for multiple reasons. One is the anatomy is smaller. Second is we do remove that part of the stomach that forms a hormone called ghrelin that functions in appetite. And so patients' hungry ghrelin levels go up. So we remove that segment of the stomach where it's produced, and that also helps in appetite control. In a bypass, it's also the loss of appetite that functions, mostly the reason why people lose weight. With appetite, with the bypass, it doesn't come back as readily as it does with the sleeve after significant weight loss.
And how soon after surgery and how long after surgery are people still coming? Or do they come to you for follow-up visits?
So the follow-ups are a week after surgery, 1 to 2 weeks, then a month after surgery, then every 3 months for the first year, every 6 months for the second year, then every year after that.
And how long after surgery do most patients see a physical loss of weight?
So patients start to see right away, even after their first visit. We talk about 5-10% weight loss is significant to change some of the metabolic parameters, sleep apnea, diabetes, the need for insulin, high blood pressure medication. So that 5 to 10 pound weight loss can occur very quickly. And then from there it continues. Weight loss continues for about 18 months, but most patients will lose most of their weight 8 months to a year.
Is there any psychological prep? I mean, are there any plateaus that the patients go through in this recovery process with the weight loss? Do they have to deal with that? Can they continue to lose weight over a longer period of time?
So plateaus do occur, but plateaus are not a failure. Plateaus are also a success because they are not gaining weight. So plateaus are not a failure. And plateaus come and go. There's no real, sometimes what happens is some patients are very excited about their weight loss, and so they weigh themselves every day. And that's like watching grass grow. This doesn't work. So we recommend once a week, but we do recommend weighing yourself because it really makes a difference, right? Because most of us are scared to get on that scale. But getting on that scale really puts you in perspective what you need to be doing. So weighing yourself once a week is important. And plateaus can occur and do occur. And then we work through them. Either we have to see what the diet is. Maybe we have to add a medication to help along. So we assess things as they come along, as they come about.
And we're talking for most of this conversation about the benefits when we talk about weight. There's obviously other health benefits to weight loss surgery, I imagine.
Right. Obviously, the blood pressure. So again, patients are told they have to make an appointment to see the doctor within a week or two after surgery because of their blood pressures. They're literally going to drop if you continue with the same dosage of medication you're taking because you don't need that much support because of your weight. So blood pressure, diabetic medications. Patients, for example, who have a gastric bypass on insulin will drop half their insulin dose the day after surgery. Their sugars will stabilize, maybe low 200s, maybe even lower than that. So there is, and some comorbidities will go away 100% after surgery. And even if patients do regain some weight back, let's say 5 years after surgery, and they require some support for their diabetes, that diabetic support is only diet and maybe metformin, which is a mild medication. It's not going to go back to their insulin needs. There are some long-term benefits that we talk about.
So this is a major health issue for people.
Right.
But you mentioned it's elective.
Right.
So is that something that insurance covers, or is it something that like people need to understand that going into something like this, it's still considered elective? They need to be able to financially afford it.
So insurance does cover. Most insurances do cover. There are stories where in the United States, in several states, some insurance companies, you have to wait a year to get surgery. Some insurances only cover one procedure for a lifetime, kind of stuff. All those things are just tactics, they're mostly related to business tactics. They're not necessarily health tactics. The studies have shown over and over again the benefits of surgery, the fact that the patient loses weight will not need so much medical support, which saves the money for the insurance companies. The thing is that a lot of patients stay with insurance companies for a certain period of time, so the insurance companies don't reap the benefits of paying for these things. Whereas the government, like the Medicare, doesn't, thinks more about society as a whole. So most insurances do cover these medications. The surgery is elective, which allows insurance companies to have a leeway to decide what they want to do and when they want to do it. Right? It's not like open heart surgery. If you need triple bypass, there's no elective. You got to do it right now. So that's why insurance have to cover that cost. But bariatrics, they have the leeway because we don't know when that obesity is going to be the be-all and end-all for that patient. So it is elective surgery.
So people shouldn't be nervous to come in and just have a consultation or speak about it if they have an issue and they want to address it. They shouldn't feel like there's that barrier between insurance and affordability. They should just come in and have the conversation.
Right, absolutely. I mean, most insurances do cover. There are some that maybe we as a hospital don't take necessarily, but we pretty much take all comers. And patients should never feel nervous about coming in for any reason, even to have a conversation.
Do you find that you have patients who come in who feel embarrassed or low self-esteem because of the way they look?
Well, by definition, they have that internally. Mm-hmm. We never make them feel that way in the office, and we always discuss with them, what they have internally, what they have socially. Is probably it definitely is affected by their weight and their perception of themselves. Not everybody is like that. Some people are very positive about themselves. They have a certain, a very good support structure at home. Some patients have that, but that never is a reason for doing or not doing surgery, or it's never a reason for seeing or not seeing a patient.
And post-surgery, I know people who have cancer, there are support groups. Are there bariatric support groups for individuals?
We have a monthly support group, where we did different topics of discussion every single month. And the good thing about the support group is it's our patients. So a lot of patients will go on the internet, look for support groups, Facebook groups, whatever, but it's from all over the place. And they don't know where it's coming from. They don't know where these patients had surgery. Our support groups, patients had surgery with us. So whatever concern or questions or worries a patient has, they know that the answer is coming from their experience with us. Mm-hmm. So that makes it much more pertinent and much more useful. So we do encourage support group participation, and anybody can participate in our support groups, even as an informational session, to see what people are talking about, to see what patients are asking, so they have more comfortable with the procedure and whatever else they have questions.
Right. That's
That's important.
Especially for informational purposes.
Yeah, and I encourage that. I encourage patients have access to support groups for free, mostly online, so they don't have to be anywhere physically if they don't feel comfortable. And they don't have to even video doesn't have to be present. As long as the audio is on, they have a question, they can ask any question they want.
That's great to have that kind of support. Yeah. I'd love to get a little personal with you and learn if you could tell us a little bit about what got you into the field of bariatrics. Is that what you knew you wanted to do when you went into medical school?
No, when I went to medical school and I was a resident, it was an evolving field. Bariatrics started in the 70s and the 80s. Actually, the first bypass was done in 1973 And then in 1980s, Dr. Walter Porres, which is a historic figure in bariatrics, started talking about treating diabetes with surgery. Whoever thought about that? So it was an evolving, emerging field. In fact, my mentor, who I trained with, was one of the first to do bariatrics in the country. His chairman of surgery went to overseas and came back with a small device, which has ended up being our laparoscopic staplers. Covidian, which is a company that started as another company. His friend, who was a patent attorney, came to his office and saw this device and said, "So what is this?" He goes, "Well, I brought this from a different country." And they patented this device, and they started the Covidian. They started the laparoscopic surgical industry. So my mentor trained with this gentleman. Back in the day, surgery was done open, and it was frowned upon, by the medical community. It was frowned upon by society, because we have this biases about obesity, that it's self-inflicted, it's psychological weakness, it's your fault. And so we started an era where this was not very popular. Right. But with time, and obviously, so by the time I trained with him, he was already doing, laparoscopy, and he was one of the first centers of excellence in America. Actually, one of the first when it came out. The movement started when I was a fellow in 2006. He was one of the first to receive it. It wasn't under the American College of Surgeons. It was under the Surgical Review Committee, but it was one of the first recognized center of excellences. So that's where I sort of, evolved from in bariatric surgery.
And you joined RUMC when?
2018.
So you come in 2018, and RUMC says we want to create this Bariatric and Metabolic Institute. What did you envision this center? What did you want it to become? What did you see at other places, that lessons learned, I'll say, where that you said, if I'm going to build this, these are things I saw were missing in other places. These are things I wanted to duplicate to make this Bariatric and Metabolic Center the place to go for weight loss surgery.
Well, my biggest concern is safety. Safety is number one. Outcome is number two. So my goal is to sleep quietly at night and have peace and quiet in my life. And that requires, concentration and making sure that outcomes are good, patients are happy. I came from an institution where I spent 10 years learning and growing, and the institution was also a center of excellence. So we had all the necessary literature and the know-how of how to start a center of excellence. So when we came into RUMC, that was our goal. Our goal was to get a center of excellence. And so we right away implemented quality metrics and quality measures to make sure that outcomes are good. And that's what we've done from day one. And that's how we've continued today. And that's the only thing that drives us is safety and patient outcomes.
I would love to know, what are the most challenging aspects of your job, but also the most rewarding?
Well, surgery can be sometimes very challenging. The anatomy is different in all comers. You can do the same sleeve in 10 different people and have 10 different technical procedures. So it's always interesting to see the differences in anatomy. It's very surprising sometimes, they're sort of it looks like ticking time bombs, and they're waiting for you to make a mistake. Somebody out up there is looking at you saying, here you go, here's an obstacle. You're like, damn, I got through this one again. So technically it can be very challenging, but that's also rewarding. Sometimes, if there are potential complications that can occur, those are very distressing to myself and the patient. So getting through those are, challenging. And just, making sure that, we continue to have a successful program.
So as we've talked to many of the different professionals from RUMC, there's often the sentiment that you can be as prepared as you possibly can be. But when you're in the moment, you have to pivot and figure it out. And it's got to be very high stress. So once you get out of those situations, what do you do to actually breathe? Like, what do you do to have free time for yourself or relax or be able to clear your mind, to be able to stay so focused and so dialed in that you're able to constantly pivot and make those decisions and under high stress situations? Like, what's your thing that you do to relax and breathe?
Well, so when I was a resident, the thing was you keep rolling until you roll home. You just keep going until you just end up in home in your bed. But I have a very good support system. I have a very good family, wife, kids, parents. Well, my mother also. So I have a very good support system. I've utilized that over the years. It's always automatic to me because I speak to my friends a lot. I speak to my family a lot. I'm pretty open in terms of conversing about my frustrations. I think that helps me a lot. In terms of pastimes, I do certain things. I'm not a golf player. I don't, I never had time. I never have developed the skills. And I don't know, just for me, it's a little tedious, but I don't like it. I like fast-paced stuff. I like more like, maybe I'll get a motorcycle. I don't know. But the thing is, I think most of my relaxation comes from socialization. Socializing is my relaxation. Talking to patients, making sure they're comfortable, and just my staff. We have a very close relationship in the office with the staff. It's sort of, it's like a family. We don't have, a hierarchy. Anybody can ask any question they want. Anybody can approach anybody they want without saying, worry about the consequences. So I like to have that environment, and that also allows for success with the program, with the patients. Everybody's happy for the most part, and patients see that.
I'd love to know, what are some of the advances you think we'll see coming down the road for this field of surgery?
Well, so, the advent of medication, we hear all this talk about, the medications that are coming down the pike. They're already available, and everybody's trying to, I guess, benefit from them financially, personally, and also for the patient. Some of these medications have been out for many years and been used in the capacity for diabetes and have the side effect of weight loss. But these medications don't come with a price. Nothing is free. Nothing is, 100%. Some people have side effects from these medications. Some people can't tolerate these medications. Some people had enough of medication. They don't want to poke themselves out, every week. But medications will play a role in helping us make bariatric or metabolic surgery successful. We'll have to combine the two, and I have patients who we've done that on, and they're very successful, and vice versa. We have patients who've started medications, they don't want them, they want surgery. We have patients who had surgery, need a little help with medication. We have patients who want surgery, but their body habitus and their BMI is to the point where our CAT scanners don't have capacity, and so they have to lose weight, so we can start on those medications. So medications will be the new addition to metabolic surgery.
Do you stay in touch with a lot of your patients?
Yes, I mean we do have follow-ups. Sometimes you don't recognize them. Sometimes they do come back for follow-ups. We do have them in support groups. So yeah, we have a really good relationship with our patients.
How does it feel when you see a patient, like you just said, your patient you don't recognize, walks in the door, and it's like, wow.
Yeah, I remember when I had a patient. It was a young woman, obviously required surgery, a large BMI, but you could tell just the features and her personality and the way she was. And she, a very attractive young woman and very smart. And right away I saw that. And I've been in communication with her over the years. She had surgery. She's lost tremendous amount of weight. Her life has been transformed. And, I call her Wonder Woman, sort of like that old show we used to watch as kids, these just, what was her name? Linda Carter. Linda Carter. So yeah, her life has transformed. She is a completely different person. Her life has been completely transformed from who she was, but she always knows who she was. And all patients who undergo weight loss surgery always still feel like they were before surgery. They don't see themselves as the new person. They still remember the old person. Mm-hmm. So, but I do have some of those stories, yeah.
And you mentioned earlier, it sounds like when a patient comes into the Bariatric Metabolic Institute, they're never alone throughout this journey. You mentioned an app, these videos, the information, the support group.
Yeah.
So this is a journey that you're very much on with them from the day they walk in the door to the day.
Our program is structured that they come in every month, and we make sure how they're progressing. We have, we follow them through the app. We follow them through our own databases, and we make sure that it always help. So if a patient comes in and their appointment has been scheduled, but it's a few months in advance that they're ready for surgery already, we will make the phone call. We'll try to get them and expedite things. So we are very hands-on through the whole journey of surgery.
And you talked about, as we talk about, it's a growing field. Roughly how many bariatric surgeries have you performed like last year?
We perform about maybe 150 cases a year. In terms of nationally, there's about 250,000 done a year. So in terms of nationally, it's interesting that the amount of people that qualify, only 1% have surgery.
Well,
Still, even from 10 years ago, the numbers haven't changed much. They went from maybe 150,000 to 250,000, but you have 22 million Americans who qualify. So that's only 1% of people who qualify get surgery. So we actually don't, access to health, insurance issues, fear, knowledge, there's multiple reasons, but we don't do enough of these surgeries and compared to the people that need it. We perform, cardiac surgery. We perform stenting. We perform tons of stenting. Even though studies have shown that stenting doesn't change life expectancy, but we still do it. We don't do enough of this surgery that's been proven to be life-saving.
So first step for somebody listening in that is considering a procedure or something like that they want to be able to come to RUMC is to go online or to be able to call in.
So patients are able to call in through our number and make an appointment. The patients are also able to make an appointment online through our website. And sometimes I think we also use doximetry. They can make appointments as well. So there's multiple ways. Patient will make a phone call. They'll get an appointment. What we do is just send out an email with our introductory information and a link to our seminar. So they can do our seminar before they come in. So when they come in, we're going to have a sort of a already informative conversation, and not from a standpoint of from teaching, but from a point of information. And so we require the seminar. We require the seminar at least within the first 2 visits coming to us, even if not. But we prefer if a patient already sees the seminar and already comes in with information and questions. About questions they have, the more interesting it is for us, because we want patients to be knowledgeable. That's our number one goal here. So to know as much as they can about the surgery.
In our final minutes together, can you tell me a little bit about your colleagues in the bariatric department? And if somebody was considering bariatric surgery, why should they choose the Bariatric and Metabolic Institute at RUMC?
Well, I think the reason they should choose the Metabolic Institute is because we really have a very individual approach. We have respect for the patient. We don't judge anybody. We have a very cohesive team. Patients feel very comfortable with us. There's 2 surgeons in the program. There's myself and Dr. Zemedis. Maybe it's intuitive, maybe it's natural. I just have a certain way that I want the program to be. And I think that patients are seeing that, and they feel very comfortable with us. There's a lot of word of mouth that they tell their friends, their families, and again, they have access to us 24/7. Any questions they have, they can always ask, and so I think that's important to have a successful program.
Well, thank you again, Dr. Barkan, for joining us today and for all that you do to keep us safe and healthy.
Thank you for having me.
Of course. As you've heard, there are highly skilled, experienced medical professionals ready to serve you at Richmond University Medical Center's Bariatric and Metabolic Institute. To learn more about our services or to schedule a consultation, please call 718-818-4020 or visit our website at rumcsi.org. That about does it for this episode of RUMC Connections. Thanks for joining us. I'm Meredith Gaskins.